Hello again from Axxess. This is Jennifer Gibson. I am a registered nurse and I'm a certified OASIS specialist and coding expert. So today we're going to talk about part 12 of our Navigating the Highway of ICD-10-CM. This part 12 is going to cover coding changes that have happened throughout the year as far as clarification with the coding clinic, as well as those changes and updates that will happen beginning October 1st of 2016 and will continue through September 30th, 2017. Please note that this information is current at the time of recording and publication, but you'll need to check your OASIS and your ICD-10 guidance, as we know that those things change quite often. Let's get started. So today our objectives are to understand the ICD-10-CM maintenance process and the governing bodies, to learn when the changes to the code set occur. We will study the changes for the 2016-2017 code set, and then we'll learn recent clarification from the coding clinic and how to apply that to coding practice. Let's begin by talking about who maintains the ICD-10-CM code set. Now, there are 4 cooperating parties that have information and input on the code set itself and the guidance that goes along with that code set. And those 4 cooperating parties are the American Hospital Association, or AHA, the American Health Information Management Association, or AHIMA, the Centers for Medicare and Medicare Services, as we well know, CMS, and the National Center for Health Statistics, or NCHS. Those 4 governing bodies cooperate and help to establish the official guidelines for coding and reporting. So how often is the code set maintained? The code set, ICD-10-CM, is updated yearly. Now, we had this previously with ICD-9, where the code sets were updated every year. But because of the transition between ICD-9 and ICD-10, we had several years where the code set did not have an official October 1st update on a yearly basis. But since we now have transitioned over to ICD-10-CM, the code set will continue to be updated at least yearly. And how that works is the proposed codes will come out first. They usually come out about midsummer, and then those codes and proposed changes are reviewed. We have a comment period like everything else we have with Medicare compliance and guidance issues. And then finally, the final set gets published after review of those comments that were submitted, and then the new changes go into effect on October 1st. Just to give you some idea about how many changes we have this year, we'll do a comparison between the total codes. Now, in 2016, with the ICD-10-CM code set, we had 69,823 codes. And for 2017, we will have 71,486 codes. Now, those updates for the 2017 code set include 1,974 new codes, 311 code deletions, and 425 code revisions. Some of the updates include something as simple as spelling corrections. We also have expansions of some of the code categories and codes. We have new diagnosis codes. We have deleted diagnosis codes. We have changes in the excludes 1 and excludes 2 notes. And in many instances, what they've done is change the excludes 1 to an excludes 2 instead. So you'll see that as you get your new code books and you go through and look at those. And obviously, we're not going to detail all of these changes in today's presentation, but certainly you'll need to pay attention just as you did with the code set was new, because there are several changes. You'll also notice there are changes to use additional code guidance, and we're going to get into some specific examples of that today. And then there are multiple new inclusionary terms, especially when you get into the psychiatric diagnoses. And again, I'll give you some examples as we go through today, but we will not cover every single change that's in the code set. You will need to go ahead and get your ICD-10 code books and begin to use those as soon as possible, close to October 1st. We'll start with the 2017 updates to the infection chapter. That's chapter 1, A00 through B99 codes. One of the biggest things is that they've added inclusionary terms at category B18 in the 2017 code set. Everything that we're going over today, when I say 27 updates, these are things that will take effect October 1st, 2016. Now, if I tell you something that's coding clinic guidance, those coding clinic guidance pieces went into effect at the time they were announced by the coding clinic. And I say that only to tell you, if you're coding, you have to pay attention to what day it is that you're coding, what the date is, because if you're coding in September of 2016, then your code set and coding may be a little bit different than it might be on October 1st if it's an updated code or an expanded code and so on. However, if it's coding clinic guidance, that can change immediately. So that could go back, several months and will carry over regardless of the calendar year. Now, just to back up again, at the category B18, we've added several inclusionary terms, and that includes making those category codes include carriers of those viral hepatitis as well as the actual diagnosis of the disease itself. We also see that there is a new code, A92.5, for Zika virus disease. And you'll see below this listed on the screen, there are 3 inclusionary terms for this particular code, including Zika virus fever, Zika virus infection, or Zika not otherwise specified. Now, we are told in the guidance to only code confirmed cases of the Zika virus. One of the next changes that I want to highlight that have to do with home care and hospice has to do with the neoplasms chapter, and those are the codes C00 through D49. We'll see revisions to the use additional code guidance that's related to tobacco use, not only here but in other chapters where that's also a use additional code guidance is noted. You'll see that in the past, in the 2016 code set, we saw history of tobacco use, and the code was Z87.891. Now, in 2017 forward, you're going to see history of tobacco dependence instead, but the code is exactly the same, Z87.891. So it's the same code, but a little different terminology that you'll notice between the two code sets in the guidance. You also will see the use of code also exocrine pancreatic insufficiency, which is a new code at K86.81 at that C25 category. And you're going to see this instruction at other chapters as well. But it's interesting to see that they've added that. You're also going to see a new use additional code to identify instruction at category C61. There's new use additional code to identify at C61 malignant neoplasm of the prostate, and that is going to include hormone sensitivity status, which is Z19.1 to Z19.2, and you'll also see the rising PSA following treatment for malignant neoplasm of prostate, which is R97.21. So they're telling us for certain malignancies of the prostate that we have to use an additional code to identify if this patient has a hormone-sensitive status or a rising PSA after they've had a malignant neoplasm of the prostate and treatment for that. Now, you're also going to notice multiple instances where not otherwise specified is changed to unspecified in the tabular index. And remember, your tabular index is the section of the book where you have the actual chapters broken down by body systems and by the disease processes. You'll see a lot of changes here as well to your excludes 1 and excludes 2 notes. The majority of the changes made those excludes 1 notes into excludes 2 notes. So make sure you pay attention to what that guidance means as far as the excludes 1 versus excludes 2. Excludes 1 are thought of more as a stop sign, whereas excludes 2 notes are thought of more as a caution sign. And if you don't really remember the difference between those and specific and how to apply those, you can go all the way back to part 1 of this 12-part series where we really focus in on the overall guidance and abbreviations and such. And that's explained, excludes 1 and excludes 2 are explained in that first part very well. You'll also notice changes to category C81. This has to do with the Hodgkin lymphoma diagnosis codes. And what they did for the 2017 edition of the code set, they pulled out classical Hodgkin lymphoma. They pulled classical from the code titles and added inclusionary terms at C81.1, C81.2, C81.3, C81.4, and C81.7. We also have a new code, D47.Z2 for Castleman disease, with instructions to code also, if applicable, human herpes virus 8 infection, and there's an excludes note at that code as well to exclude Kaposi sarcoma. We also have new subcategories at D49.5, which is neoplasm of unspecified behavior of other genitourinary organs. They have given us laterality on the D49.51, neoplasm of unspecified behavior of kidney. You now can specify if this is right kidney or left kidney. And then at D49.59, we have neoplasm of unspecified behavior of other genitourinary organ. The next chapter we're going to highlight some changes in would be the chapter for blood diseases, D50 to D89. Again, you'll see in this chapter multiple changes to the excludes 1 and excludes 2 notes. You're going to see at category D78 intraoperative and post-procedural complications of the spleen. What they did at that category, they removed the and hematoma from the code titles there, and they added a whole new category for hematoma and seromas, and that new category became D78.3, post-procedural hematoma and seroma of the spleen following a procedure. And you're going to see in subsequent chapters where they did the same thing with post-procedural complication codes. They pulled out the and hematoma in most every chapter and gave it its own category. We also have a new category in this chapter for D89.4, which is mast cell activation syndrome and related disorders. And there's a related excludes 1 note for this category as well. So the next chapter in your code book is the chapter that deals with endocrine and diabetes and other types of issues. And I want to highlight that there was some coding clinic clarification that came out from the coding clinic in March or April of 2016. And just so you know, if you're not familiar with the coding clinic, what happens, the American Hospital Association and AHEMA, they publish what's basically guidance and interpretation of the code set as questions are sent in, and that coding clinic guidance gives us direction on how we are to interpret certain codes or how to code things. And one of the things that we were always wondering about, when the code set transitioned over to ICD-10, we didn't have the ability to automatically assume diabetes and all these conditions that generally happen with diabetes like we could with I9. For example, in ICD-9, we could assume if a patient was diabetic and they had osteomyelitis, and it really wasn't us assuming, it was the code set, assumed a relationship. And so if the doctor said the patient was diabetic and they had osteomyelitis and didn't directly correlate those two together, the code set assumed that relationship. When ICD-10 came out, that was not the case. We were told that we could not associate osteomyelitis or any of the other issues like neuropathy or kidney disease or anything else just because of the diabetes and the manifestation. Whether or not the doctor said that or not, we couldn't assume. Well, lots of people wrote into the coding clinic and some clarity came out and said the following: ICD-10-CM official guidelines for coding and reporting says the term with means associated with or due to when it appears in a code title, the alphabetic index, or an instructional note in the tabular index. This is how it's meant to be interpreted when assigning codes for diabetes with associated manifestations and or conditions. The classification assumes a relationship or a cause and effect relationship between diabetes and certain other diseases of the kidneys, nerves, and circulatory system. What this means is when you're in your alphabetic index and your code book and you look up diabetes and you see the next indentation is with, and the next indentation has a list of disease processes, because it's listed under with, the code set assumes the relationship between diabetes and those conditions, and you can code those without the physician specifically relating those conditions together. For example, if you look at your alphabetic index under diabetes, I've got just a few here. You have diabetes, diabetic, mellitus, sugar, E11.9, and the next little sub-entry you see with amyotrophy or arthropathy or autonomic polyneuropathy or cataracts and Charcot's, and this list goes on. What that means is even if the doctor doesn't say that the patient's cataracts are due to diabetes, because it's listed under diabetes with, I can assume that relationship because the classification assumes that relationship and go ahead and code it to E11.36. And I couldn't do that before coding clinic guidance came out, okay? You will notice when you get in your code books, however, and you look at this, that there is still no osteomyelitis listed under diabetes with. So we still cannot assume those two are related. We will have to get physician clarification for diabetic osteomyelitis. Once we have that documented in the chart that the two are related, then we would use a diabetes with other manifestation and then code the osteomyelitis right after that. Now, the only exception to what I've just said about diabetes with is if the physician documents something other than diabetes as the underlying cause of the other condition, don't code as a diabetic complication. So in other words, we just talked about how we could relate cataracts with diabetes because of how it's listed. If, however, the doctor came in and said this is cataracts due to aging, we would not code diabetic cataract in that case, okay? So just make sure you understand that. Just a couple more points regarding the clarification on diabetes and with. You'll see listed here on the slide, they went on to say any condition listed under with is assumed to be related to diabetes according to the guidance unless the physician relates the condition to something else. ICD-10-CM does not presume a linkage between diabetes and osteomyelitis. The provider must document a linkage or a relationship between those two conditions before it can be coded as such. Here's an example the coding clinic gave us to help understand and clarify what we've just learned. A woman with type 1 diabetes mellitus for 40 years developed chronic osteomyelitis of the right heel. The provider also noted chronic renal failure due to diabetes. Patient was also treated for hypoglycemia at the clinic. Now flip to diabetes in your book. You'll notice there's no presumed linkage under with the diabetes type 1 and the osteomyelitis. For that reason, you'll see the coding clinic has given us the answers here. The codes in this scenario would be M86.671, E10.641, E10.29, and N18.9. Some other changes you're going to notice in the endocrine chapter, E00 through E89 codes, is that there are new use additional code conventions at categories E08, E09, E11, and E13. You'll also notice new code categories and categories related to eye conditions, expanded for laterality at E08.32, E08.33, E08.34, E08.35, and E08.37, and these carry over into all the other types, E9, E10, E11, and E13. Now what you're going to see in the 7th character position, there's now a 7th character required, and that 7th character you have to add either a 1, 2, 3, or 9. The 1 is the right eye, 2 is left eye, 3 is bilateral eyes, and 9 is unspecified eyes. You're also going to notice in chapter E00 through E89, there's new excludes 1 notes at E16.0, which is drug-induced hypoglycemia without coma, and it tells you that excludes the E09.692 code. You'll also notice exclusionary terms at E16.1, other hypoglycemia, and E16.2, hypoglycemia unspecified. There's also a new Z code that we're going to use with diabetes codes quite often, and that new Z code is Z79.84, which is long-term use of oral hypoglycemic drug. So we've always had long-term use of insulin. Now we have long-term use of oral hypoglycemic drug to go with our diabetes codes, which I think is a great, great thing. In this same chapter, we also have some new codes such as E66.2, which is morbid severe obesity with alveolar hypoventilation syndrome. We also have E78.00, pure hypercholesterolemia unspecified, and E78.01, familial hypercholesterolemia. What they did, they took those which were once inclusionary terms under E78, and they gave them their own code so that you can see the different kinds. At E84 cystic fibrosis category, you also again see that code also exocrine pancreatic insufficiency, which is K86.81. Now, the next chapter we're going to go over is the circulatory chapter, I00 through I99, and there's some really crazy new changes here. The way this looks on the slide, it looks like they took all these codes out, but what they did, they deleted the old chapter block I10 to I15 and all the guidance that went with that and replaced it with a new chapter block, which is hypertensive diseases I10 to I16. You're going to notice there's new use additional code to identify, and you'll see the history of tobacco dependence instead of use like it was before. We talked about that just a few slides back. It's the same code, it's just a different description there in the history of tobacco dependence now. The hypertensive diseases category, I10 to I16, has an excludes one note for neonatal hypertension and primary pulmonary hypertension, and then an excludes two for hypertensive disease complicating pregnancy, childbirth, and the puerperium. So, of course, those are new because of the category change. The biggest change, however, the codes are still the same at I10, that's still primary hypertension, I11 is still hypertensive heart disease, I12 is still hypertensive chronic kidney disease, I13 is still hypertensive heart and chronic kidney disease, I15 is still secondary hypertension, but we have a whole new coding category here at I16 for hypertensive crisis. And those hypertensive crisis codes are broken down further. You'll notice there's a code also any identified hypertensive disease, I10 to I15, and the new codes include I16.0, which is hypertensive urgency, I16.1, hypertensive emergency, and I16.9, hypertensive crisis unspecified. Now, I certainly wouldn't expect any of these codes to be your first listed or primary diagnosis on an OASIS, but you might very well use these codes for inpatient diagnoses or something that required a treatment change in the last 14 days. So just know that these codes are here and we can use them beginning October 1st. You're also going to notice in this same chapter multiple new codes in the I63 and I69 cognitive deficits subcategories. Now remember, when you're coding strokes and cognitive issues and brain injuries and so on, I63 is an acute setting category. That's when the stroke is actually happening or the brain bleed is actually happening, whereas I69 is the sequela category and the one that we use most often in home care. You'll see several new codes regarding post-procedural hemorrhage and hematoma following procedures here as well. All right, now we're going to go from the official guidance that begins October 1st. There was some coding clinic clarification from the AHEMA and AHA coding clinic regarding heart failure. This came out early in 2016 as well. And what they said was because we have new information about heart failure and that's become kind of standardized terminology, that we can begin to use some new terms and go ahead and code according to these terms when they're in the documentation in the record. So you have HFpEF, which means heart failure with preserved ejection fraction. And the coding clinic says that may be referred to as heart failure with preserved systolic function or diastolic heart failure. So if you have any of those terms, you can code this as diastolic heart failure. The same goes with HFrEF, which is heart failure with reduced ejection fraction. That may be called heart failure with reduced systolic function or systolic heart failure. The coding clinic said the coder can code systolic or diastolic heart failure using these terms from the provider. And we did have to code a whole lot of unspecified heart failure, or CHF, because we didn't have this information, but we might have had HFpEF or HFrEF in the documentation somewhere, and if so, we can now code it as systolic or diastolic accordingly. Now, beginning October 1st, 2017 forward, because of the coding clinic guidance that goes with the 2017 changes, there's also new guidance related to hypertension. The classification, I-10 to I-16, presumes a causal relationship between hypertension and heart involvement and hypertension and kidney involvement, as these two conditions are linked by the term with in the alphabetic index. These conditions should be coded as related even in the absence of provider documentation explicitly linking them, unless the documentation clearly states the conditions are unrelated. Now, what does that mean? Not every heart problem can be linked and coded to something other than I-10 or I-11 or I-12. What this is saying is that there are certain things when you look under hypertension with that you can code. And let's get into the specifics here. The 2017 official guidance, Part 1, Section 9.A.1 says, hypertension with heart conditions classified to I-50 or I-51.4 through I-51.9 are assigned a code from category I-11, hypertensive heart disease, because they're linked with. So if you have hypertension with heart failure, that automatically becomes a hypertensive heart disease, and then you would code the heart failure as well. And you'll notice the second bullet here, those same conditions, I-50 point or I-51.4 through I-51.9 with hypertension are coded separately if the provider specifically documented a different cause. Now, obviously if the doctor says the patient has heart failure due to a drug overdose or due to something else, then you wouldn't automatically connect them. But otherwise, if there is no correlation, there's nothing documented as to what caused the heart disease or heart conditions at I-50 or I-51.4 through I-51.9, then you will, because the category assumes the connection, you'll go ahead and code those to category I-11. Again, that's regulation beginning October 1st. Now, let's get into our respiratory coding. That's chapter J00 through J99. You'll notice there is that revision of the use additional code information, again, from history of tobacco use to history of tobacco dependence, although it's the same code. You also have at J47.0 bronchiectasis with lower respiratory infection. They added a use additional code to identify the infection. Notice here. We also added a new category, J95.86, for that post-procedural hematoma and seroma. And you'll notice there's also an use additional code to identify the infection there as well. We also see that they deleted the code J98.5, diseases of the mediastinum not elsewhere classified, and what they did, they broke these into separate codes as well. Rather than having the inclusionary term, they made a new code, J98.51 for mediastinitis and J98.59 for other diseases of mediastinum not elsewhere classified. Next, we get into our integumentary changes at L00 through L99. There's a new code under L98.1 for factitial dermatitis with an excludes one notes for excoriation or skin picking disorder, F42.4. We also have new codes L98.7, excessive and redundant skin and subcutaneous tissue, with inclusionary terms for loose or sagging skin following bariatric surgery weight loss or due to dietary weight loss or not otherwise specified. And there's a new excludes 2 at that code as well, so pay attention if you're going to be coding that. Next, we want to talk about some coding clinic clarification regarding therapy coding. One of the things that I've seen a lot, there still continues to be lots of questions about therapy coding because the ICD-10 code set, the general guidelines and conventions for this code set, when it came out, really did away with the therapy-only codes. And we were instructed that therapists need to code the condition they're actually treating. And so we still got into a lot of people coding symptoms when they needed to just be coding the disease. And so a lot of questions were asked to the coding clinic regarding that. So in second quarter of this year, the coding clinic put out information regarding therapy coding and gave us several examples that I want to share with you. What they told us about coding therapy and rehab services is this: if a symptom is integral to the diagnosis, which requires the therapy services, that symptom is not coded separately. So all of the things that you find in the R chapters, like unsteady gait or abnormality of gait or ataxic gait, all of those things, we really need to consider whether or not it's inherent or integral to that diagnosis, the underlying diagnosis or not, and code accordingly, because you only code symptom codes if there is no underlying disease diagnosis yet. The first example the coding clinic gave us is this: patient was diagnosed with a right traumatic anterior cruciate ligament or ACL tear and presents for therapy. The physician's prescription documents right ACL tear, right knee pain, and difficulty walking. The coding clinic says you only code S83.511D for your therapy services. We don't assign codes for pain or difficulty walking, as these are signs and symptoms that are routinely associated with an ACL tear. The second diagnosis that they gave us is as follows: the patient has Parkinson's disease with frequent falls and lack of coordination. In this case, you code G20 for Parkinson's disease as well as R29.6 for the falls, because falls are not integral to Parkinson's disease. According to the coding clinic, that's how we're coding that. Example 3. Patient has low back pain and sciatica with left lower extremity pain radiating to the knee and difficulty walking and needs physical therapy. The primary reason for care is to resolve pain and improve mobility. In this case, you code M54.52, low back pain and sciatica, and then you also code R26.2, difficulty walking, since it's not integral to sciatica or lumbago. All right, so hopefully that provides some clarity as to the therapy coding and ICD-10. And again, that information from the coding clinic applies at the time it was published. If you didn't know about it, that's fine. Just, maybe write a QAPI plan of action that you just learned about it on such and such date, and that you will apply the following coding guidance to your coding going forward, and you should be fine. Let's talk a little bit next about your updates to the mental behavioral chapter. These codes are F01 through F99. The 2017 updates, again, go into effect October 1st of 2016. You'll notice in this chapter, they've added multiple inclusionary terms throughout the chapter. And if you don't remember what inclusionary terms are, you'll go back to part 1 of the series. Inclusionary terms are disease names or additional information that's added under a diagnosis to let you know that these things are included in this diagnosis title. So there are multiple inclusionary terms added to code titles throughout the chapter for mental and behavioral disorders. In category F02, dementia and other diseases classified elsewhere, they've added new includes and code first conventions. They've put in that includes major neurocognitive disorder and other diseases classified elsewhere. And you'll also see code first dementia with Parkinsonism, G31.83, Huntington's disease, G10, prion disease, A81.9, and traumatic brain injury, S06. You're also going to see that inclusionary terms at most dependence codes now include use, So if the physician states use and the inclusionary term says use, you're at the correct code. We also have a bunch of new codes here. I don't know that we'll use a lot of these in the home health population since most of those patients are seniors unless you're doing a lot of private insurance. But you'll see F32.81 premenstrual dysphoric disorder. You'll see F34.81 disruptive mood deregulation disorder, F34.89 other specified persistent mood disorders, F42.2 mixed obsessional thoughts and acts, F42.3 hoarding disorder, F42.4 is that new excoriation or skin picking disorder, and then F42.8 is other obsessive compulsive disorder, and F42.9 is your unspecified obsessive compulsive disorder. So hopefully your psychiatric nurses will love that you have more things to choose from here that certainly can apply in home health, like hoarding and skin picking and those types of things. You also have some new codes for F50.81 binge eating disorder, F50.89 other specified eating disorder, F64.0 transsexualism, F80.82 social pragmatic communication disorder. When we get into our updates for the 2017 year on the code set for musculoskeletal and connective tissues, you'll see there's a new category, M04, for autoinflammatory syndromes, and this excludes Crohn's disease, but you'll see new codes for M04.1 periodic fever syndromes, M04.2 cryopyrin-associated periodic syndromes, M04.8 other inflammatory syndromes, and M04.9 autoinflammatory syndromes unspecified. You also see new categories, and this is probably one that makes me chuckle the most. New categories, M21.6, other acquired deformities of foot. This includes your M21.61 bunion and M21.62 bunionette. So I guess that's just a little bitty bunion. I don't know. I found that comical. But you're also going to notice that there is a sixth character which will give you laterality. 611 is bunion of right foot, 612 bunion of left foot, 619 bunion of unspecified foot. I hope you don't use that. Surely we know which foot we're talking about. And then with your bunionette, again, you have 621 for bunionette of right foot, 622 bunionette of left foot, and 629 bunionette of unspecified foot. I've just never seen bunionette ever in 24 years of being a nurse. That just tickles me. Maybe it's something new that they've come up with. I'll have to look that up. All right, new subcategory, M25.54, that's pain in the joints of the hand. They have given us a sixth character and added new codes so that we can specify laterality. So you have M25.541, pain in the joints of the right hand, M25.542, pain in the joints of the left hand, M25.549, pain in the joints of unspecified hands. And again, with these codes, if that pain is inherent to an underlying disease process, you don't code these codes unless a category tells you specifically to add the code for pain in the joints. If you have, say, for example, rheumatoid arthritis, that's inherent to most of those people who have rheumatoid arthritis that they have pain in their hands. So you wouldn't need to code that in addition. So keep that in mind. We also have a new subcategory in this chapter, M26.60, for temporomandibular joint disorder unspecified. And you'll see the category is further broken down into new codes for right TMJ, left TMJ, bilateral TMJ, or unspecified. You have new codes at subcategory M50.02, cervical disc disorder with myelopathy, mid-cervical region. What they did, they took and broke that category out further so that you can see specifically what level you're talking about in the cervical disc disorder. So M50.020 means you don't know, it's not specified the level. 0.021 is C4 to C5 level. 022 is C5 to C6 level, and then 023 is C6 to C7 level. You're also going to notice the new codes at subcategory M50.12, which is your cervical disc disorder with radiculopathy, mid-cervical region. Again, they took that and broke it out into 6-character codes, with the 6th character telling what level of radiculopathy and cervical disc disorder that we have. So 121 is C4, C5 level, 122 is C5, C6 level, 123 is C6 to C7 level, and of course the M50.120 is the unspecified. You're going to notice those same type of changes at the subcategories M50.22, other cervical disc displacement, mid-cervical region, M50.32, which is disc degeneration, mid-cervical region. You're going to see it at M50.82, other cervical disc disorders, and M50.92, cervical disc disorder, unspecified. There's a new code at M62.84 for sarcopenia. There's a new category, M96.84, and this is again where they've pulled the hematoma off the complication codes, given it its own category for post-procedural hematoma and seroma of a musculoskeletal structure following a procedure. There's also a new category, M97, that I'm actually pretty excited about because we see this happen quite a lot in home health. And that is a periprosthetic fracture around internal prosthetic joint. And the subcategories include M97.0, which is your hip joint, M97.1 for knee joint, 0.2 is the ankle joint, 0.3 is the shoulder joint, 0.4 is the elbow joint, 0.8 is other, and 0.9 is unspecified. All right, we also have some 2017 updates to the chapter on signs and symptoms, which is R00 through R99. We have a new category, R29.7, which is your National Institutes of Health stroke scores. We also have a new code, R73.03 for prediabetes. We have a new code, R97.20, elevated prostate specific antigen or PSA. We also have a new code, R97.21 for rising PSA following treatment for malignant neoplasm of prostate. So basically, we've gone over the changes. Of course, as we said before, these are not all of the changes. There are volumes of changes to the ICD-10 code set beginning October 1st, 2017. We have highlighted those that are most important to us in home health. But basically, all of that tells us that we need to make sure we purchase new code books for use beginning October 1st, 2016 through September 30th, 2017, because only in your code book are you going to get the new and changed information, including your use additional code or code also, or the inclusionary notes or the excludes one, excludes two notes. You don't get that with the lookup system unless you're using Decision Health's online coding center. Remember to check out Axxess's library of on-demand training webinars as we continue to update changes as they occur. And remember, all webinar content is correct as of the time it was recorded, and it may change accordingly as the coding clinic comes out and gives other clarification, or other changes may apply with the OASIS code set and so on. Just be aware that if you're listening to these webinars after the fact, that information may have changed. We hope that you've enjoyed this 12-part series on ICD-10 coding. We hope that you found it helpful. You can best reach me by email, but you certainly are welcome to call me on my extension as well. And that extension is the 214-575-7711 number, and my extension is 3917. Feel free to leave me a voicemail, or you can email me at jgibson@axxess.com. Thank you very much for attending today, and we hope you have a blessed day. And of course, thank you for all that you do to make sure that the patients receive health care in the home where they want to be and where they deserve to be. And we know that without your job, whatever that job might be, whether it's coding or visiting nurse or DON or administrator, biller, whomever, if it weren't for you being at your job every day doing what you do, these patients would not have the opportunity to receive the care that they get in the home. So thank you again for what you do. We hope to see you again on future webinar topics. That page is always being updated, so be sure that you come back and look at our training page often to see if there are additional titles added, okay? Have a wonderful day, and thank you again for joining us. Bye-bye.
Thank you for joining our webinar today. We know that your time is valuable and are happy you chose to spend it with Axxess. At Axxess, we're proud to offer a variety of training resources to keep you in the know on industry news and updates. You can register for additional trainings and watch on-demand training videos through our software or at Axxess.com, where you can also find tutorials, online manuals, and answers to frequently asked questions. We're always just a call or click away. Feel free to call us at 866-795-5990 or email us at support@Axxess.com. All of our expert client experience representatives have a home healthcare background. They've been in your shoes and know the industry inside and out. Join the conversation and connect with us on our social channels. We'll keep you up to date with what's going on in the industry and share resources to help you grow your business and improve your patient outcomes. Thank you again for your time today and for choosing Axxess, your provider of complete home healthcare services, software, and solutions.